Good morning, students. We will continue our GI system or gastrointestinal system. So today's topic for discussion is drugs for peptic ulcer. Before going to drugs for peptic ulcer, we have to know what is peptic ulcer diseases and what are the pathophysiology related to peptic ulcer diseases. As an introduction, acid peptic diseases includes GERD, gastroesophageal reflux disease, peptic ulcer, and stress-related mucosal injuries like Curling's and Cushing's ulcer. Curling's ulcer is most commonly seen in burns patients, and Cushing's ulcers, which is associated with the head injury patients. So these acid peptic diseases are a group of diseases where there is some imbalance in the acid peptic secretion. Okay, out of that, peptic ulcer, which occurs in the GI tract, gastrointestinal tract, which is exposed to gastric acid and pepsin, mainly in the stomach and duodenum. So the peptic ulcer occurs in the parts of GI tract which is exposed to gastric acid and pepsin, mainly our stomach and duodenum. Now the pathophysiology of this group or this disease is mainly it is an imbalance between some aggravating factors and some defensive factors. So in our body we have got some defensive mechanisms to protect our gastrointestinal tract from the acid which is normally secreted in our body. So the disease, the peptic ulcer disease or acid peptic disease, is due to imbalance between these aggressive and defensive factors. Aggressive factors are acid, pepsin and bile, which is normally seen in our body, and then H. pylori infection. So one infection which is associated with our peptic disease is H. pylori infection, Helicobacter pylori. And the defensive factors which normally occur in our body are gastric mucosa, bicarbonate, prostaglandin, high mucosal blood flow, and innate resistance of mucosal cells. And you will be knowing there are different types of cells in our gastric mucosa, like parietal cells, like chief cells, parietal or oxyntic cells, mucosal cells which secretes mucosa, gastrin cells which secretes gastrin, D cells which secrete somatostatin and all. So they all are secreting their own products in our cells. They itself will act as a defensive factor, and also they will itself will be a aggressive factors. Okay, like that there are some risk factors also which are associated to these factors, our aggressive or defensive factors. There are some risk factors which are which can contribute to formation of peptic ulcer. They are mainly our H. pylori infection and the drugs like aspirin and NSAIDs. Aspirin and NSAIDs, mainly the painkillers. They are generally known as painkillers. And also our habits like smoking, alcohol, emotional stress, and also some other drugs like bisphosphonate and glucocorticoids. They all will act as a factor which can aggravate the disease. Now we can see how the gastric secretion is formed, or the regulation of gastric acid secretion. So the final step for HCl production is release of H plus from the parietal cells. So the terminal enzyme H plus K plus ATPase, which secretes H plus ion in apical canaliculi of parietal cell, is activated by three factors, mainly the histamine, acetylcholine and gastrin. Out of the three, histamine is the most important one. Here you can see three different structure of parietal cells or different forms of parietal cells. One is neurocrine pathway, the other one is hormonal pathway, and the third one is paracrine pathway. So the neurocrine pathway will be activated by activating the M3 receptors, which is an acetylcholine receptor. So when the acetylcholine is released from neuronal end, it will activate the M3 receptor on the parietal cell, and which secretes the H plus ion. In the second group, it is an hormonal pathway. Here the gastrin cells which are seen in our stomach mucosa, they will secrete the gastrin which flows through blood and activate the CCK2 receptors which is seen in the parietal cell, and they will release H plus ion. The other group, the last group, parietal cell is activated by our H2 receptors by release of histamine from ECL cells, that is enterochromaffin like cell. Enterochromaffin like cells will secrete the histamine and activate the H2 receptor, which finally will release the H plus ion, and it is the commonest pathway of production of H plus ion. And another pathway is seen here, D cells, that means D cells which secretes the somatostatin. Somatostatin has got a negative feedback on the H plus release. They will inhibit the release of H plus ions. Okay. Again, you can see here a large parietal cell, and the final step H plus K plus ATPase. Here there is a ECL cells, enterochromaffin like cell. D cell is there which release the somatostatin, gastrin by gastric cells, and acetylcholine. So the gastrin and the somatostatin has got an action on ECL cell also. They have got a direct action on parietal cells, they also have a additional action on ECL cells which will release the histamine. So they have got an additional action. Here the larger arrow is towards the ECL cell. So the majority of gastrin will be activating the ECL cells and release of histamine. So it is a indirect pathway. Okay. And the final step for all these type of these pathway, the final step is H plus K plus ATPase activation and release of H plus ion. And this is a energy needed process, because here there will be a huge amount of H plus ions will be there, and in the canaliculae there will be only a few less amount of H plus ion. Here will be a large amount of H plus ions will be there. Here in the canal there will be a few amount of H plus ion. So we have to move the H plus ion against the concentration gradient. That means we need energy. That's why H plus A plus ATP. So it is an energy needed process or energy needed pump. Histamine has got a dominant role. In the previous picture itself, I have shown that histamine directly from the ECL cells will activate the H2 receptors. Gastrin and acetylcholine indirectly release histamine from paracrine enterochromaffin like cells called histaminocytes. H2 activate H plus K plus ATPase through CAMP, and the muscarinic and gastric receptors will be acting through IP3DAG pathway, which mobilizes the intracellular calcium. And the final step is the H plus K plus ATPase activation and release of H plus ion. Physiological significance of the synergism. So this is a synergism. There is a synergism going with this H2 release and our gastrin and all. So the physiological significance is high rate of secretion is stimulated with a small change in each stimuli. So each stimuli, when there is a small stimulus itself, it can release high amount of H plus ions. And the therapeutic significance is that by secretion is markedly inhibited by blocking action of only one trigger. So we can inhibit the histamine, it can reduce a large amount of release of H plus ion. So that's the clinical or the therapeutical significance of this synergism. And few words about the parietal cell. They are highly specialized for secreting concentrated acid. Highly specialized for secreting concentrated acid. They are packed with the mitochondria to supply energy to the apical proton pumps. As I have already told, there is an energy needed process. The H plus ions is moving against the concentration gradient. So these cells are highly packed with the mitochondria, which moves the H plus ion out of the parietal cell against a concentration gradient. Here the structure of parietal cell, we can see that there are a numerous amount of parietal cells here. Enormous amount of mitochondria here, which will give energy to the cells to release the H plus ion to our canaliculae, which is against the concentration gradient. Again, you can see two picture of parietal cell. One is the resting phase and the other one is secreting phase. In the resting phase, these H plus ATPase pumps forms a tubulovesicle structure and which lies away from the canaliculae. You can see here it is away from the canaliculae, and there are receptors. When it is activated, so when these receptors are activated, the cell get cell will move to secreting mode. Here then this tubular vesicle will fuses towards the canaliculi. We can see this is near to the canaliculi which secretes the H plus ion. Here it is away from the canaliculi. Okay. At rest, proton pumps are sequestrated within the parietal cells as a compartment known as tubular vesicles. When the parietal cells begin secrete, the vesicles fuse to the apical membrane of canaliculi, substantially amplifying the apical membrane area and positioning the proton pumps to begin acid secretion. Now we move to the treatment part. So we have got some goals for the treatment. The main problem in a peptic ulcer patient is that they will be having a high, or they will be having a abdominal pain. Abdominal pain, intra-abdominal pain will be their main complaint. So the first goal is to relieve that pain. Next one is the promotion of ulcer healing. So there is already an ulcer in the stomach. We have to heal that ulcer. Next goal is to prevention of complications. And finally, prevention of relapse. We have to prevent from again development of this disease. The drugs or the drugs for peptic ulcer are grouped as the one which reduces the acid secretion. The first group of drug is which will helps to reduce the acid secretion. Out of that, there is 3 group of drugs. One is proton pump inhibitors: Omeprazole, S-omeprazole, Pantoprazole, Lansoprazole, Rabiprazole, and Dexrabiprozole. Next group is H2 antagonist: Cimetidine, Ranitidine, Famotidine, Roxetidine. And the third group is anticholinergic drugs: Pyransepine, Propanthyline, and Oxyphenonium. So these all group of drugs, they have got action on acid secretion. They will reduces the acid secretion. Second group of drug is which will act on the already formed acid. So they will neutralizes the gastric acids. They are also known as antacids. It can be given by 2 ways. One is systemic method by like sodium bicarbonate and sodium citrate. Second group is non-systemic, but mainly by orally: magnesium hydroxide, aluminum hydroxide, and calcium carbonate. These all are commonly seen in our antacid syrups. Third group is which the group of drugs which helps to enhance the defense mechanism. In the previous slides, I have told that this is an imbalance between the defensive and aggressive factors. So the first 2 groups will help to reduce the aggressive factors. The third group is which helps to increase the defensive mechanism. It enhances the mucosal defense by prostaglandin analogs like misoprostol. And the last 2 groups, one is ulcer protective, which forms a protective covering on the ulcers which is already formed in our stomach: sucralfate, colloidal bismuth subcitrate. And the last group is anti-H. pylori drug. So the H. pylori, Helicobacter pylori, has got a high relation between the development of disease. So we have to treat that H. pylori disease. And the drugs used are amoxicillin, clarithromycin, metronidazole, tinidazole, and tetracycline. So these are the antibiotics which are used to treat H. pylori disease. Now the first group, our proton pump inhibitor. The drugs are Omeprazole, Lansoprazole, Pantoprazole, Rabiprazole, S-omeprazole, Dexrabiprozole. Out of that, the Omeprazole is the prototype drug. So we will be discussing the features of Omeprazole. They are the most common group of drugs in peptic ulcer disease. So the proton pump inhibitors are the most common group of drugs used in peptic ulcer disease. They have overtaken the H2 blockers due to the efficacy and its safety. So initial days we were using H2 blockers. Now we prefer our proton pump inhibitors because they are highly efficacious and also highly safety. It can completely abolish the HCl secretion both in resting and stimulated phase. I have shown a figure of parietal cell. One is in the resting phase and the other one is the stimulated phase. So our proton pump inhibitors can block or can abolish the HCl secretion in both resting and stimulated parietal cells. Now the mechanism of action of these proton pump inhibitors. They are substituted benzimidazole, the chemical structure, which inhibit the final common pathway of acid secretion. So in the previous slides I have shown that the final step for production of acid is our H plus K plus ATPase pump, or release of H plus ion through H plus K plus ATPase. So our proton pumps, or this H plus K plus ATPase, is also known as proton pump. So our proton pump inhibitor means they are inhibiting the proton pump, which is the final common pathway of acid secretion. All of these are prodrugs. So all of the proton pump inhibitors are prodrugs. So it has to be activated in our body for that, and they are all inactive in the neutral pH. For the activation of prodrug, we need a pH less than 5. So only when the pH is less than 5, our proton pump inhibitors will be activated, and it forms a 2 charged cation molecule covalent binding to SH group of H plus K plus ATPase, and it is a irreversible process. So the inhibition of proton pump by the proton pump inhibitors is an irreversible process, and for the further production of HCl, acid secretion resumes only when new H plus ATPase, H plus K plus ATPase is synthesized, and it takes about 18 hours. Okay. The pharmacokinetics, they are entry coated to prevent the disintegration. So all of the proton pumps are given as entry coated. They will be in a capsule form, which is entry coated, and it should not be broken or crushed before taking in. And it can be administered, or it should be administered 30 minutes to 1 hour prior to any food. So if you are giving this drug, we have to give 30 minutes or 30 to 1 minute, 1 hour before the food. And they all has got good oral oil bioavailability and also have high plasma protein binding capacity, mainly metabolized by your liver, mainly the CYP enzymes, and is excreted through the urine. So mainly metabolized in our liver and excreted through the urine. Omeprazole, it is the first PPA which was introduced in 1986, and the bioavailability is about 50%, metabolized by the CYP enzymes in our liver. The T half is about 1 hour. The metabolite excreted in the urine, and there is no need of dose adjustment, or there is no need of dose modification in liver disease or kidney disease or in elderly. So there is no need of dose modification in these conditions. S-omeprazole, it is an S enantiomer of omeprazole. Again, he said goes a higher oral bioavailability, the rate of elimination is slow, so the duration of T half is longer, so duration of action will be long, and also got a higher healing rate of erosive gastritis, better for GERD relief, and also the dose is about 20 to 40 milligram OD. Lansoprazole, it is potent than omeprazole, has got a higher oral availability, faster action, but it is partly reversible and less drug interactions. Pantoprazole, similar in potency of omeprazole, which is acid stable, higher bioavailability, and also lesser drug interactions. And pantoprazole is again a S enantiomer of pantoprazole, which is, let's say, twice potency than omeprazole. Rabiprazole, which has got a fastest acid suppression. The potency and efficacy is similar to omeprazole. The dose is 20 milligram OD. Next is dexrabiprazole, similar acid suppression, but the half dose of rabiprazole, it is 10 to 20 milligram OD. Now we can see the bioavailability and T half of different groups of drugs. Majority of them has got a bioavailability more than 60%. Okay, majority of drugs has got bioavailability more than 60%. And when we talking about the T half also, it's within 1 to 2 hours. Majority of drugs has got a T half was 1 to 2 hours. Now you can answer this question. It is given in the previous slide that the half-life of proton pump inhibitor is 1.5 hour only. These drugs are generally given once daily. How this can be justified? So in the previous slide I have shown that the T half is about 2 hours. Within 2 hours the T half is finishing, and the majority of drugs are given once daily. So how can we justify this? That's by proton pump inhibitors, they will irreversibly inhibit the H plus K plus ATPase. They are irreversible inhibitors of H plus K plus ATPase. and this is known as hit and run drugs. Hit and run drugs. They will hit that proton pump and they will destroy that proton pump. So for the further production of HCl, we need a new pump. It takes 18 hours. That's why it is given only once a day. Okay, and this comes under a group of hit and run drugs. Use of proton pumps. Peptic ulcer diseases, H. pylori associated ulcer, NSAID induced ulcer, prevention of free bleeding from ulcer. In gastroesophageal reflux diseases, non-ulcer dyspepsia, prevention of stress-related mucosal bleeding, gastrinoma and other hypersecretory conditions. Adverse effects, we can group into two groups. One is short-term adverse effects and long-term or prolonged use. In short-term, it can lead to nausea, loose stools, headache, abdominal pain, muscle and joint pain. In prolonged use, it can lead to atrophic gastritis, vitamin B12 deficiency, risk for bone fracture due to osteoporosis, and gastric carcinoids. And there are some important drug interactions for proton pump inhibitors, mainly omeprazole. This will decreases the gastric acidity. We know that it reduces the gastric production, so obviously it will reduces the gastric acidity. But when gastric acidity is reduced, it can reduce the bioavailability of some drugs like ketoconazole, itraconazole, digoxin and atazanavir. And again, the omeprazole is mainly metabolized by our CYP enzymes in the liver. The omeprazole is a enzyme inhibitor. So will inhibit the CYP enzymes and it will decrease the metabolism of drugs like warfarin, diazepam and phenytoin. So the warfarin, diazepam, phenytoin all are metabolized by the CYP enzymes. It will increase, so when the CYP enzyme is inhibited, it will decreases the metabolism of warfarin, diazepam and phenytoin, which leads to adverse effects of these drugs. Again, it will interfere with the activation of clopidogrel by inhibiting the CYP2C19. Clopidogrel is an antiplatelet drug. So it is also a prodrug which should be activated in our body by cytochrome enzymes. So when the cytochrome CYP2C19 is inhibited by our omeprazole, then the clopidogrel will not act. So this happens only when the omeprazole and clopidogrel is given simultaneously. Okay. And clarithromycin, which inhibits the omeprazole metabolism. Clarithromycin is an antibiotic. It will inhibit the omeprazole metabolism. Okay. Next group of drugs which reduces the acid secretion is H2 receptor antagonist. H2 receptor antagonist. They are reversible competitive inhibitor of H2 receptors. The other one was irreversible inhibitors. Here it is reversible inhibitor of competitive inhibitor of H2 receptor. They are highly selective. Here I have got no action on H1 or H3 receptors. So the histamine has got 3 receptors, H1, H2 and H3 receptors. Out of this, the H2 receptor antagonist will act only on H2 receptors. So it is highly selective. And also it is very effective in suppressing the basal acid secretion. Basal acid secretion means our nocturnal acid secretion. And our nocturnal or the basal acid secretion is mainly due to histamine release. So it is more effective to suppress that basal activation. The drugs are cimetidine, ranitidine, famotidine and roxatidine. When we compare the features of these drugs, out of that our cimetidine has got a higher bioavailability. It is got a 80% of bioavailability for cimetidine. When we talk about the potency, the famotidine has got a higher potency. It is about 20 to 50 times than our cimetidine. The half-life is also higher in famotidine. It is 2.5 to 4 hours. Again, the duration of action also is about 12 hours in famotidine. When we talk about the interaction, the inhibition of CYP enzyme, it is 0. So it has got no interaction with our enzyme. When the ranitidine has got a little inhibition on CYP enzyme. Again, the dose also, the cimetidine is 400 mg BD, famotidine is about 20 mg BD. So we will need a lesser dose due to high potency. ADME. ADME means absorption, distribution, metabolism. It is the pharmacokinetics of H2 blockers. Absorption is not interfered by the presence of food in the stomach. It can cross the placenta and reach the milk. So when a woman is pregnant, it can reach to the fetus, and also when a lady is feeding, the baby can reach through milk. It cannot penetrate the brain. The penetration is the brain is poor because it is more hydrophilic. The H2 blockers are more hydrophilic. That's why it cannot cross our blood-brain barrier, which is a hydrophobic region. It has got a lipid layers. Okay. About 2/3 of the drug is excreted unchanged in the urine. So only 1/3 of our drug is using in our body. The rest will be excreted unchanged in our urine and bile. And here the dose reduction is needed in renal failure. So initially in the PPAs, I have told there is no need of dose modification in renal, liver disease or in elderly. But here we need a dose relation or dose reduction in renal failure patients. Here also there are many important interactions, mainly in cimetidine. So cimetidine can inhibit the CYP450, that is our CYP enzyme. It can inhibit the CYP enzyme, which increases the concentration of warfarin, theophylline, pentoin, metronidazole, and lidocaine and imidipine. So the metabolism of these drugs by CYP enzyme will be inhibited, and it will lead to adverse effects of those drugs. And also it will compete for creatinine and procainamide for tubular secretion. So our cimetidine will compete for the creatinine and procainamide in the tubular secretion, which will increases the chance for increasing the creatinine and procainamide. Antacids will reduces the absorption of all H2 blockers. So it is a negative inhibition of antacids and H2 blockers. They will inhibit the absorption of H2 blockers. Now the adverse drug reactions, they are common, like diarrhea, headache, fatigue and malaise. And when the cimetidine is given IV, there will be CNS symptoms. So CNS symptoms will be seen when the cimetidine is given IV. And the important adverse of cimetidine is that it can lead to gynecomastia or impotence and galactorrhea. That's why cimetidine is not used nowadays. Due to the development of gynecomastia and impotence and galactorrhea, it is not used nowadays. And also when this is given in a rapid IV, when the H2 blockers are given rapid IV, it can lead to bradycardia and hypotension due to the suppression of H2 receptors on the heart. So it can block the H2 receptors directly, which is present on our heart, and leads to bradycardia and hypotension. And the cimetidine is not used nowadays because that it can lead to gynecomastia, impotence and galactorrhea. So we can stop here, and we will continue the rest in next class. So thank you. Go through the presentation and also try to attend the quiz in the Google Classroom. Thank you once again. Stay home, stay safe. With regards, Dr. Rahul. Thank you.